Welcome back to those of you who are returning, and welcome for those of you who are here for the first time. We at the PCJ are so excited to have Tim Black join us today. Tim is the Director of Consulting at Whitebird Clinic. He has a background in runaway and homeless youth, harm reduction, and street outreach. And he began working with Cahoots as a crisis intervention worker in 2010. He's here today to talk to us about the Cahoots operation and how it's impacted the communities that so far have taken up with using Cahoots as a way to deal with some of the mental health and substance abuse crises in their communities. His work with Whitebird and Cahoots has put him in touch with cities across North America looking to implement services based on the Cahoots model. Some of you in this audience are probably here for that reason. Programs based on the Cahoots model have been implemented in Olympia, Washington, and Denver, Colorado. If I understand correctly, my own hometown of Hartford, Connecticut took up with Cahoots about a year or two ago. I'm not sure if you know what's going on there, but if you do, I would love to hear what's happening with my hometown. In addition to his work with Whitebird Clinic, Tim also serves as the Vice President of the Board of Directors of Eugene's community-supported shelters. So I'm really excited to have Tim here today. Tim has asked that we have a conversation instead of a presentation and then open up to Q&A. So we're going to have this conversation, and afterwards, as is typical, we will open it up for Q&A. Please do, as soon as you have questions, put them in a chat and we'll take each question as they come in. I suspect we'll have lots of questions, so I'll try to keep my questions short. I have to admit that's going to be difficult because I've been looking forward to this for about 6 months at least. So Tim Black, welcome to the program in criminal justice. It's wonderful to have you here.
Thank you. It's very exciting to be here with you all today.
So why don't we start by having you tell us about the history of Cahoots? I know it's been in existence for about 30 years, but it's hard not to wonder how this took off. What was going on in Eugene at the time that made this a possibility?
Sure. When we talk about Cahoots, which started in 1989, it's really hard to separate, the origins of Cahoots from the rest of Whitebird Clinic, which is our, kind of parent organization. Whitebird Clinic was founded in late 1969, recognizing some of the early impacts of deinstitutionalization, looking at what was going on in our community with so many young people, experimenting with psychedelics and just an inadequate response to the emerging needs in our community. Our founders had a background in academics, psychology professors at the University of Oregon, some other doctors and providers from our immediate community. And there was this real strong desire to find a way to actually, really connect with folks that were in these behavioral health crises and, experiencing addiction. And so with input from the folks down at the Haight-Ashbury Free Clinic in San Francisco and Outside In up in Portland, we started to operate the Whitebird Socio-Medical Aid Station here in Eugene and Springfield. Before we had a brick and mortar location, we were able to get a crisis line together. And as soon as that number started ringing, we were hearing about situations where it just made a lot more sense for us to actually be out there in the community, literally meeting somebody where they were at for some resolution. And, borrowing the vernacular of the late 60s and early 70s, we called that the bummer squad. And so before we even had, a physical location for folks to go to when they were in crisis, we were leaning on this network of volunteers, of providers from our community to be a part of that bummer squad and respond with whatever supplies we could muster in a brown paper bag and a personal vehicle. For 20 years, we offered that bummer squad resource as we could, with funding and staffing, varying. At the same time, law enforcement was really starting to trust Whitebird Clinic as a destination to bring folks in crisis. There's this documentary from the University of Oregon from, I think, 1974 that really underscores that point with this very powerful visual of, the kind of the classic Dodge Charger patrol car showing up in front of Whitebird Clinic. And then, an officer gets out and takes the handcuffs off of a young person who looks to be in distress and then hands them over to Whitebird Clinic staff, then take him inside and support him as he, works through a really challenging experience. So we really became this trusted alternative to arrest or to hospitalization for local law enforcement. and the community just really trusted us, to be able to provide this kind of Bummer Squad resource through some of our work at rock and roll concerts, at festivals, at even some of the anti-war protests at the University of Oregon. We started to really recognize that an integrated health approach was the most effective. By having a pairing of a crisis worker and a medical personnel, we were able to really handle anything that came across our plates at those festivals, in those kind of large crowd settings. Your crisis worker can do crowd control and has clean hands to get medical supplies if there's a medical situation going on, vice versa. The EMT can really provide that safety for the scene while the crisis worker really engages with somebody directly. And so, through that kind of proving ground, we really honed in on this integrated health approach. And then in the late 80s, as community policing was taking off, the Eugene city manager approached us and said, "Hey, we see this amazing work that you're doing. We really value that role that you are serving in our community, and we'd like to find some ways to really kind of formalize that and provide a lot more structure and resources." And so that's how we ended up with a retired ambulance, an old police radio, and officially started to offer services as Cahoots on the 4th of July in '89.
89. Okay, so between in the 1970s and 80s, that's when there was this kind of renegade who
Right.
was willing to do whatever joins the team, but it wasn't until 1989 when it became official.
Absolutely.
And it was at that, so up until 1989, had this idea to pair the medic with the social worker or the crisis intervention person. When did that emerge? That this duo with the
that duo really emerged probably in 72 or 73. This is almost 25 years before mobile integrated health became part of EMS, right? It was really just a recognition that what was working for us in these kind of complex, crowded environments of festivals and concerts, that really translated well to working in unpredictable environments, being out in the streets, in an encampment, in somebody's home, and it just made sense, right? Treat the whole person at every intersection. There isn't. I can't think of a single physical health ailment that doesn't have some sort of behavioral health, connection, right? If you feel bad, physically you feel bad, emotionally you're probably going to feel bad, and for folks who might be coming from communities or families where they were discouraged from talking about how they're feeling, there's not that ability to really connect with or, discuss what you're experiencing on that kind of behavioral health level. But if you can call and say, "Hey, Bummer Squad," or, "Hey, Cahoots, I've been having an upset stomach. I've been losing my appetite. It's been going on for a few weeks, and I would really like to talk to somebody about what I can do for my stomach." And then we start talking with you, and you find out, okay, well, you lost your job. You're getting ready to move. There's tension with your partner. Starting to get a full picture that there's more to this than just quit eating gluten every day. And so that's so that really opens the door for us to become a lot more accessible to folks. Our work with folks who are using substances, experiencing addiction, we need to have that medical component as a part of our response. Folks might be trying to avoid getting police involved, and so they could have a friend who's overdosing and they want Cahoots to come and talk about sobering and detox, but really what we end up doing is applying Narcan. And again, that's because folks are calling us because they feel safe enough to reach out, knowing that we can handle a lot of these different situations that they might find themselves in.
Yeah. Okay. So you've been quoted in the media as saying that the organization's success has not happened overnight. This didn't occur overnight. There are many small but important details to address, and what you describe as a wide range of stakeholders to engage to effectively implement this approach that so many folks around the country want. How has Cahoots changed exactly or evolved in approach since 1989, although you might even want to take it back to 1974? What kinds of things emerged that Cahoots responded to that helped to shape the model that it is now?
Sure. Our focus originally was really just on behavioral health and work and addiction. And as soon as we started to really engage in that work, you start to find all these different areas where there's a point of intersection with those kind of two primary goals. And we had to really shape our responses to address those intersectional points. And so over the years, we have seen our role as, very kind of intermittent case managers, for folks who are experiencing homelessness, become a very huge part of our work. When we first started, Eugene was a pretty quiet town, didn't have a very big homeless population. And, you fast forward to today where we have the highest rate of homelessness per capita in the United States. And so when we've had to add these, new services, new components to what Cahoots is doing, it's always been informed by the community, either by us reaching out to partner agencies or community leaders, or receiving that feedback, from those same groups unsolicited. And when we found a moment where there's something that we need to do better, there's something else that we need to be including, we are working with our funders, with those partners in traditional public safety to make sure that that can be a component of our services. Something that really stood out for me about 5-6 years ago, there's a lot of pushback from command at the police department around our medical responses, and this real lack of recognition of how important it was to maintain that as a part of our response. And it was support from the medical community that really helped us reinforce, and underscore why we needed to maintain that component in our services.
So let me take us through like a typical call, from, I want to say from beginning to end, but you don't have to do that. What does this look like? Someone calls emergency 911 or whatever. What happens at that point?
Sure. So somebody's experiencing a crisis out in the community, and we need to recognize first and foremost that crisis is occurring because there's some sort of need that has gone unmet. So that crisis occurs in the community. A call is placed to the public safety dispatch system, whether it's the individual themselves or a third party. A call is placed. Those same call takers who are answering the non-emergency police line, fire, EMS, the one answering 911, are also the ones who are answering those calls for Cahoots services. And so, you contact public safety dispatch, and they're going to be triaging that call for priority and urgency, as well as, what's the best resource to send. So somebody might be calling in specifically for Cahoots, or they perceive their experience to be an emergency, and so they call 911 and say, I need the fire department to, get Elvis out of my basement. That's a situation where Cahoots is probably going to be the most appropriate resource to deploy. And so those dispatchers and the call takers really have that authority, in collaboration with the Cahoots response teams, to really determine, what calls are going to be sent to us. When it's agreed that, this is a call for a Cahoots response, the Cahoots response teams are being dispatched on the same priority channels as law enforcement, and are out just kind of patrolling. We're not some sort of on-call resource where we got to, muster a couple of folks and get there within an hour. We're actively patrolling the streets. A Cahoots team generally is going to be responding without other public safety resources. So without an ambulance, without a fire engine, definitely, without police cars. And our objective is always oriented around recognition that the individual that's in crisis is the expert in their experience. And we have an obligation to listen, use empathy, unconditional positive regard, and really engage with that individual, to find some immediate de-escalation and stabilization, and then look at what else that person might need to feel supported in the future. All of our work is really oriented through the least intervention necessary. And so we really try not to be attached to outcomes that aren't what the patient has identified. And there's always an intention to really try and resolve things where somebody is, in the community, because we need to be really mindful of displacement. If somebody's experiencing homelessness and they have finally found that camp where they can trust their neighbors to, and they feel really secure there, the last thing that we want to do is yank them across town, drop them off the hospital where they're going to be for 45 minutes, and then have them try to figure out how to get back to that safe place that they finally found. Folks don't have a lot of access to the transportation in the first place. And so, we just don't want folks stranded, and so if we do need to take somebody somewhere, then that's going to be a free ride. Everything that Cahoots does is free of charge. And when we do take somebody to another facility, we're going to be accompanying that with a transfer of care, really engaging with the staff that are receiving that person in crisis, and really talk about, what it is that we hope to get out of that experience for the patient. We're going to empower that patient by really giving them as much information as possible about what the services are they're going to encounter. And then, really finally, it's just a recognition that if they need to call us again, that's not some sort of failure. That's just time for us to come back out and look at a different approach. So we do that. Our teams do that for 12 hours a day for their shifts, and around the clock, to the tune of over 20,000 calls a year.
So my understanding is that about 18% of the calls that come into 911 are then routed to Cahoots.
Correct.
And that in 1 year you received about 24,000 calls, and only about 1% of those did you need to bring in backup from police. Is that
Yes.
correct?
Yes.
So is that because it's mind-boggling.
Mhm.
Most people think that we really require the presence of police, and if we don't have them, that things will go awry. This suggests a really good kind of triage system that enables you to kind of send the right people to the right emergencies. What has been the relationship between police and the Cahoots team over the last, say, 3 decades? How has that evolved over time?
Yeah, when we first got the official formal Cahoots started, there was a lot of apprehension. The police were concerned that the hippies now had a dispatch radio, and we're running around on that same system. And for us, the hippies on that system were kind of worried about, potentially getting arrested, or just what the implications were of having that much exposure to the criminal legal system. A lot of that quickly dissipated, though, as we started to engage in the work as first responders. We may completely disagree. We could be on polar opposite ends of the spectrum, but the fact that we're both in this system as first responders, gives us a point of commonality. And so, for the last 30 plus years, we've really built off of that foundation of recognizing that we have separate roles within first response, but that we are ultimately first responders and are going to need to be able to trust each other even if we don't agree. And so it's really kind of been about trust. This past year has been an opportunity to really, I think, exercise that trusting relationship, even when we disagree. When the Black Lives Matter protests really started to gain momentum here in Oregon in May last year, we sat down with the chief of police and said, look, we're not going to discourage our employees from going out and exercising their First Amendment rights. You're going to see faces in the crowd that are going to be on the van tomorrow night, and we need your officers to understand that, this is part of our work. And the response from the chief was, we expect to see your members out in the streets. And I think we're really fortunate, there's a lot of privilege that comes with the fact that locally our law enforcement understands our objectives, to keep them out of these situations, and is supportive of that. Chief Skinner has said several times that he doesn't want officers in Eugene responding for mental health calls. He doesn't want officers out in homeless encampments. This is not their work, and they shouldn't be doing it. And so, we've been able to really kind of capitalize on that. And, I think that's a really kind of special thing. It's not something that we experience with our partners in the city of Springfield, which is a much more conservative community, where, that just this past year, they paid out $4.5 million to the family of Stacey Kenny, who was killed by police at a traffic stop while in a behavioral health crisis.
Trust is what you say is one of the 3 critical things needed in order to make a system like this work. Mm-hmm. Eugene, Oregon, as I understand it, is predominantly white, about 83% white, 4% Asian. Blacks represent about 2% of the population. Written materials from Cahoots indicates that trust from the population served as essential for success. So is community culture of care. This leads me to wonder about how Cahoots will be, how successful or effective it will be in more diverse cities. I mentioned that I am from Hartford, Connecticut, and Hartford is implementing Cahoots and began that process about 2 years ago. It's one of these cities, and it's doing it to address its mental health and substance abuse issues. There are 2 questions or set of questions that I have about this. How is the Cahoots model developed in Eugene, and maybe to some extent also Springfield, being tailored to racially diverse cities with a history of racial antagonism and distrust between police and communities of color? That's the first. If you want, I can let you answer that, or I can answer.
Sure. Let's dive into that a little bit, because that's something that really comes up a lot. What we have built here in Eugene and Springfield is something that we built for our community. When we were designing this program, when I was, working out on the van in 2010, I wasn't thinking about what this was going to look like in Hartford or, Miami or San Francisco. And that's important because this is not a cookie cutter program. This isn't some sort of one size fits all thing. There are aspects of this service that we provide to our community that could be and should be emulated in other municipalities. But if somebody is spending the time with me as a consultant from Whitebird Clinic talking about this, first and foremost, I'm a white cis man. I am not the only person you should be talking to about police reform and criminal justice work. But really, if they're going to spend an hour talking with Whitebird Clinic and Cahoots, they need to be spending 10 hours with their own community members. Where areas where we really see a lot of early success in either the planning stages or initial implementation are communities that have really invested the time to understand how this service is going to affect impacted communities, where there is adequate and majority representation of lived experience within the advisory panels or coalitions that are forming to really support these endeavors.
Thank you.
Yeah.
Okay, so there is one other aspect of this that you mentioned to deal in part with, or maybe wholly with the trust question. It's been reported that there's been a creation of a separate phone line for Cahoots that would be disconnected from the police department. Can you elaborate on this and suggest other ways of developing trust? I mean, it would build on aspects of what you just said. Especially or in the context of understandably distrusting communities.
Yeah, for a long time, we have just said, okay, we're using the public safety number because generally folks in the United States are conditioned to call the police when they're in crisis. Recognizing now that's really coming from, a white perspective, where it is safe for me to call police when I'm in a situation where I need support. And that's something that we were not, I think, quick enough to really recognize within our community here. And with the feedback that we're getting from our advisory committee and other community leaders, we are really pushing for shifting the Cahoots point of access over to 988. And so this is, that initiative that the FCC started to work on in 2019. We're expecting rollout in 2022. But what this would do is really put us into a more integrated crisis response system, where just like you call 911 when you break your leg or you're having a heart attack, when you're in that behavioral health crisis, when you're feeling suicidal, you would call 988. That's not just for Cahoots. That's, another way to get connected to crisis staff, who can work with you over the phone if that's going to meet your needs. Would connect us with crisis stabilization centers and really start to create a separate first response system. Even CIT International talks about the fact that having police be so integrated into how folks access crisis right now is further reinforcing the assumption that police need to be a part of these responses, and is really putting more of the obligation to address the rampant mental health problems in our nation through criminal legal endeavors rather than through the lens of public health.
Right. Thank you for making that point so clearly. So I have to admit that I marvel at at how very cheap it is to run at least Cahoots in Eugene. I think it's about $2 million. Mm-hmm. How effective it seems to be, and how efficient Cahoots is. And this is all in some ways relative to what would otherwise be offered by the police. But also, I marvel at how much it saves costs for other public institutions. So your materials make it very clear that the programs in Eugene and Springfield, it basically leads to major cost savings, upwards of $8.5 million for police, $14 million for ER costs. These are just estimates, but it actually makes me wonder if these estimates are underestimates because of how you calculate these savings. First, it seems like in a significant amount of the work that Cahoots does likely diverts people away from jails as well. You kind of mention it in some of the materials, or gets mentioned in some of the materials, but doesn't get highlighted or doesn't seem to be incorporated into costs. If it is the case that 60% of Cahoots's clients are homeless and 30% live with severe and persistent mental health illnesses, this is what we're talking about in terms of these frequent users. And the costs associated with pretrial detention, arrest and pretrial detention, and the constant of it, that's huge. I'm assuming that cost is not incorporated into this. One assumes that because of Cahoots, there's been a reduction in arrests, jail admissions, detentions, and all of the collateral consequences that are associated with that for individuals, their families, and communities. I wonder if you want to speak to that before I suggest another cost savings that results because of Cahoots.
Sure. it's been interesting, despite all of this collaboration that we've had with law enforcement, over the 30 plus years that we've been doing this. Whenever it's come time to really say, okay, help us, verify, quantify and verify the financial impact that we're making on the criminal legal system in our county, it's crickets, and so these estimates that we've put out there are our best estimates. But to really, I think, get a more independent lens on that, we're working with outside evaluators to do some program analysis so that we can start to get a bigger body of literature that's more than just our own nonprofit putting those estimates out there. But that's I think that, but what you're bringing up really speaks to our role in prevention, and the need for mobile crisis to really support folks from falling through the cracks all the way. There's a kind of a common saying here in our community that Cahoots is the thread. We don't have a social safety net. We have a bunch of hammocks. And so Cahoots is the thread that's rolling around town, stitching all those hammocks together, and as a result, there are all of these these cost savings, these beneficial impacts that we have in those traditional systems. We just need their help to really underscore, and kind of quantify what that impact is.
Well, you just let me know. I have a few friends here at Harvard who might be willing to help with some of these estimates. Here's the second way that I think that there might be these huge cost savings to your community, and then I'll hand it over to our community because the list of questions is growing very quickly. So to start, I'll say in 2018, Chicago spent basically $113 million to settle police misconduct cases. New York City taxpayers spent a whopping $230 million to pay off 6,400 plus lawsuits settled against the NYPD in 2017 and 2018. I bring this up because it would seem that to the extent that you can significantly reduce the number of encounters, police-citizen encounters, you probably are also reducing the number of opportunities that things could go very badly, people get hurt or harmed, and these lawsuits take hold. You mentioned a bit earlier a lawsuit that led to over $5 million payout. It would seem that this would also be one of the cost savings associated with implementing a Cahoots kind of model. At the very least, because it significantly reduces the amount of citizen police contact, which then reduces the likelihood of any of these kinds of incidences happening. Have you all thought about the extent to which Cahoots might actually be benefiting the community in this way as well?
Absolutely, and that's something that comes up in our negotiations. With our contract is what is it in those kind of untold costs, the ones that you're not planning, that you can't predict, those settlements. That's something that came up when we were really looking at how the city of Springfield was going to fund us. And, as we saw, despite those conversations, we still had, a death by police. And it's something that, we definitely are bringing up as we engage with other communities. And it's something that we hear from law enforcement advocates, even is that these services being implemented effectively, reduce that liability, and reduce that potential for, a violent and deadly police encounter as a result of a behavioral health crisis.
Yeah, it's an incredible program.
Thank you.
So I thank you so much for answering my questions. I'm going to open it up to our community so that they can ask theirs. There are a lot of questions to get through already. So the first is by Javon Sobreno Wheeler. Would you like to answer, ask your question of Tim?
I would. Thanks so much for putting this on. This has been a great discussion. We're trying to set up an alternate public safety response in Cambridge. I'm on the city council, and there's other folks who are on the task force to help set this up, and we're looking at Cahoots as one model. One of the things that's been really on my mind as one of the counselors who will have to approve the budget is just trying to understand how the Cahoots budget model works and sort of how funding has been secured, how much of it comes from the cities, what % of the budget comes from the cities of Eugene and Springfield, and then if that sort of push and pull over the budget has ever been a concern, and just how you've been able to secure a steady funding stream over the years.
Sure. Answering your last question first, we've been able to secure this consistent funding stream because of both the public reception of our program over the decades and a recognition, at least, of our cost savings to the emergency rooms and, reduced ambulance rides, leaving aside contention around cost savings for criminal legal stuff. The overall operating Cahoots budget came out last fiscal year to $2.3 million. We received about 2/3 of that from the cities of Eugene and Springfield. The majority of the remainder was made up by a grant from the state of Oregon that our county Health and Human Services provides. And then we also do, private donor, fundraising. And then we do receive a relatively small but growing wraparound service funding payment from our local Medicaid provider. That's recognition of our impact in social determinants of health, how much we're really reducing population health spending, just generally improving outcomes, for Medicaid patients covered in our county. And so, we're not doing fee-for-service work. This isn't something where we're trying to bill Medicaid for the transport, to the hospital or for a crisis intervention, to really, make our services accessible and allow our clinicians to focus on de-escalation and stabilization. We've been able to really kind of find these alternative funding streams.
Thank you, Siobhan. Next up is Thomas Carnes. Oh, no, actually, I'm sorry. It's Drew Herzig. I don't want anyone to lose their spots. Drew, would you like to ask your question?
Well, thanks very much. I'm involved with the Police Advisory Board here in Pittsfield, Massachusetts, and one of the big concerns is dispatching a social worker or a mental health worker to a potentially dangerous situation. If you're doing this just through the dispatch, how can you possibly know whether the situation is potentially dangerous or not, and who's going to bear the ultimate responsibility for that? Thank you.
So the simple answer is, that's another great question. Simple answer is very well thought out indemnification language in our service agreement. We have hold harmless both ways with our, within our contract. But on a more fundamental level, I think we really need to recognize how triggering just a uniform itself can be, in these responses. And that a lot of what we do to really manage these situations that could be perceived as potentially becoming unsafe is by first sending a different visual message, by wearing a simpler uniform that's generally a t-shirt or a hoodie, some work pants and some boots. We don't have a whole bunch of different things on a belt, like a taser, handcuffs, pepper spray, all of those different things. We send a different message. We say this is not a police response by wearing a shirt with a high contrast logo that has just the image of the Wiper Clinic on it. That helps us address some, potential language barriers. And if maybe you're, you have your vision impaired, or we're waking you up, and so you got to, rub the sleep out of your eyes, things look a little fuzzy. You see that Wiper logo. Those are things that we can really do to instill, in folks that we're encountering for the first time, that this isn't going to go the same way, as it might with the police. Additionally, we do a lot of work around scene safety, and in our training process, really train our staff to look at every component of the situation that we're arriving in. Are we out in a crowded park, where there's going to be an audience and somebody might be reluctant to engage with us? Is it raining? Is it dark out? Are there roommates that the person might not feel comfortable, having around while they open up to us? And so all of those different components to what's going on in the environment where a situation's occurring help keep our team safe. And finally, there's a fundamental philosophical difference in how we approach our situations compared to law enforcement. When you go through police academy, you're told to assume that every interaction that you have is going to become deadly, and that there's this warrior mindset that is really instilled in law enforcement. And we compare that to the Cahoots approach, which really relies on mutual trust, and an expression of that mutual trust when we engage with somebody. I am committed to keeping, this interaction safe, Sandra, and I assume that you are committed to keeping this safe for us too. And it's through that establishment of that mutual trust that we can then really build that rapport and really engage with somebody in meaningful and safer ways than they would encounter with law enforcement.
Based on your response, I'm wondering if you can't say a little bit about training. I don't want to take up too much time because we have so many people, but you mentioned training and how well-trained folks are. Can you say a little bit about what is a part of this training?
Yeah, so our training overall for Cahoots responders, regardless of what experience you come to us with, it doesn't matter what kind of alphabet soup you got for credentials behind your name. It doesn't matter what fire department you may have worked for if you're an EMT. Everybody who comes to work on Cahoots is going to go through about 30 hours of class time where we're really focusing on, how to work within the public safety system, what de-escalation looks like from our perspective, common diagnoses, common prescriptions, and their side effects, and then really digging into humanistic intervention components. I mentioned unconditional positive regard. That's one that folks are generally pretty familiar with. And then after you've gone through that class time, we apply that in a field training experience that generally takes about 500 hours to get through. So it takes 4 to 6 months really to train up to be a responder on the Cahoots program. When you're doing that field training, you're a third person writing with a response team. And as you gain more and more skills, incrementally, you're applying those to the work, and you get to a point where your field trainer, when I was a crisis trainee, I was ready to go when my crisis trainer didn't have to do anything on a shift because I was working the radio, I was writing the reports, I was handling the interventions and doing the transfers of care. And so, in a nutshell, that's our process. It's involved, it's committee led, everybody gets a mentor to work with them one-on-one. And that the de-escalation, that scene safety is just one component of the training that we have to do for our staff.
So next up is Deborah O'Brien. Deborah, would you like to ask your question?
Sure. I was wondering if you had to create changes when the 911 calls were being sent to you. Did you have to get law changes in order to have that done?
We were in a position where the laws in the state of Oregon at that time were complementary to the service delivery that we wanted to pursue. That's something that is a challenge, for other municipalities where there may be, an ambulance company that is contracted to be the only transport, to the emergency room. When we were consulting with the program crisis response unit up in Olympia, Washington, we hit an impasse where EMTs had to be employees of the fire department, but the fire department wasn't willing to loan personnel to that crisis response. And so they chose to go with more of a peer support presence in addition to that more traditional mental health response. So that's a place where every community being different, every set of regulations being different, we need to really recognize that this is a program that needs to be tailored to fit within those parameters. That being said, there's always room to advocate, and lobby for changes to those laws.
Thank you, Deborah. Next up is Queen Cheyenne Wade. Queen Cheyenne, would you like to ask your question?
Yes, thank you for coming here and speaking with us today. My question is just if you could explain a little bit more about the difference between the non-clinician first responder model and the co-responder model, and really what the difference between those of, a community-based kind of worker versus a social worker, or police and the social worker kind of riding along together. What is the difference between those models? Thank you.
Absolutely. Yeah, great question, Queen, and it's good to hear from you again.
Yeah.
So what Queen's bringing up is very important. So many communities across the United States have adopted this co-responder model, and what the co-response model is generally a clinician, a master's level clinician who's embedded with police patrol and is responding to crisis situations with that law enforcement present throughout the duration of the intervention. You compare that to more community-based responder models like Cahoots, like other more traditional mobile crisis teams, where there isn't that law enforcement presence involved. Cahoots kind of sits somewhere in between those two models because we are first responders using the public safety system to be dispatched. But generally speaking, we don't have law enforcement involved in our response. Something that's really interesting is that in the last year, CIT International, so this is the organization that formed as a result of the Memphis model of crisis intervention for law enforcement. This is the kind of the North Star as far as crisis intervention training for police departments in the United States. Even CIT International is now saying that co-response is problematic because what it does is, like I said, obligates the criminal legal system to address the public health issue of mental illness instead of really looking at this through the lens of public health. It reinforces the fact that police will be involved in crisis and that we should be looking to police to respond to those crisis situations, which means that we may let them ferment or escalate until they get to the point where an emergency response is the only appropriate method to respond to those situations. Anecdotally, we've heard from patients in communities where co-response is the standard, that there's potential for there to be a bias in favor of law enforcement for those clinicians. And it becomes really challenging to, engage with those groups because there is a certain level of defensiveness, and protection, around their approach. And that's something that we see even here within the state of Oregon, where, we're trying to bring our model statewide. And one of the biggest hurdles we're up against right now is counties that have been relying on this co-response, for so long, and clinicians who are worried about, how it might affect their employment. Something else that comes up for me, and this is a brief tangent, is around credentialing in general. With co-response, you got to be that qualified mental health professional. We're talking about licensed clinical social workers, PsyDs, whatever. That's that alphabet soup. The ability to get that advanced credentials is predicated on a high degree of privilege, and folks who are able to access that level of credentialing and certification might not want to be working out in an unpredictable environment like the streets. And so with Cahoots, we focus more on what would be an undergraduate, kind of equivalent level of education and experience, heavily weighted in favor of that experience, more so if it's, somebody who has lived experience with mental health, addiction or homelessness. And that's really allowed us to put first responders who have direct experience and can say, hey, I've walked this. I've been here where you are right now, and let me tell you how I got out of it, and we're going to work with you to get you there too. We just see a lot more power in how we're able to connect with folks because we focus more on what it is that you bring to the table as opposed to where you got your degree.
Thank you, Queen Cheyenne. So next up is Thomas Carnes. Thomas, would you like to ask your question?
Sure. Thank you for talking on this. I was just curious about when you do work with the police, is there any training with them on the handoff in the event that a situation does escalate out of your control and you need help, like you talked about with backup?
Mm-hmm. Yeah, so it's very rare. On average, something like once a day, that we're calling for that police cover. And there are generally two reasons that we're going to be calling for that police support. Either we have somebody who's in a situation where they're unable to maintain their personal safety or the safety of those around them, and they're unwilling to voluntarily go with Cahoots to get connected to a higher level of care, or we're dealing with physical violence and aggression that we're not able to verbally de-escalate. In both of those situations, Cahoots teams are always carrying a police radio. We work on the same dispatch frequencies as patrol. And so that means that when we need that cover, I just key the mic and we're getting, the units that are right there. They know where we are. They see the addresses for our calls. So there's a lot of awareness of kind of what we're up to at any given time. When we call for police support, we're just reaching dispatch and then saying, hey, we need this support right away. And that right away could be at the normal flow of traffic, or it could be lights and sirens. When officers arrive on scene, the protocol is to engage with the Cahoots personnel first. That's the other reason that we wear such easily identifiable clothing, is because we want that law enforcement officer to see, okay, there's the Cahoots staff, and kind of reinforce a moment to pause. From there, patrol will talk to the Cahoots responders about what's going on, and then the patrol officer, Cahoots responders, and the patient will sit down to have a conversation. Police like to call it the Cahoots or cuffs. It's really, we're in this moment, you either got to quit acting this way, or, really we can't leave you where you are, and we have to get you connected to a higher level of care. And even though the officer is right there on scene, there's still an opportunity for that individual to say, okay, I get it. I'm going to, I'll be nice, or this has reinforced the severity of my situation, and now I'm going to choose to go with Cahoots voluntarily to the hospital. If that's what happens, then that officer is going to disengage and say, hey, great, all right, have a good night. But if we are unable to maintain that voluntary interaction and we do need police support to get somebody to that higher level of care, the Cahoots team doesn't just walk away at that point. We then become two sets of civilian eyes who can observe what's going on during that transport to the hospital or to the sobering center. When that patrol car parks in the ambulance bay to get that patient out of the patrol car and into the hospital, the Cahoots team is right there with them. We provide the same transfer of care and advocacy that we would for the patients as if we had brought them in without law enforcement. And then, we tell that officer, thanks for being there when we needed you, and really recognize that, they came out to support us too. And so that's how we kind of further instill that trust in our partners in public safety.
Thank you.
So Heather Kelly has two questions. Heather, would you like to ask your questions?
Yes, thank you so much. So my first one was, if our community doesn't have a strong organization that's responding to mental and behavioral health calls, what are your thoughts about having a response team based under the fire department? San Francisco's trying this, Oakland just kind of revamped and decided to go that direction. Love to hear what you're thinking about that.
Yeah, I struggle with that a little bit. In part because one of the reasons that Cahoots was founded was to really recognize the mistrust in traditional public institutions. And things are generally better with fire departments than they are with police, but that doesn't necessarily mean that every community is going to feel comfortable reaching out, even if it is housed within the fire department. We see a hybrid model of that with what's going on in Portland at the street response up there. I'm trying to remain cautiously optimistic about it, but we also really need to divorce ourselves from the idea that it's only traditional 501c3s, or mental health organizations that could provide this service. I guarantee in communities across the U.S. there are mutual aid networks. There are street medicine teams. There are homeless outreach groups who are doing this because they care, not because it's how they're getting their paycheck. And those groups may be in a position to, very effectively provide this service if they can get the support to, kind of stand up that more traditional institution themselves.
Thank you. Is it okay to ask my second question?
Please do.
Okay, I'm just wondering, Tim, what you think about this $100 billion or $1 billion that's in the American Rescue Plan that's supposed to help states across the country move towards a Cahoots kind of setup?
Mm-hmm. Yeah, we're honored, to be recognized that way in that legislation. As it works its way through committee and into public comments, where we stand with it is that we want to really make sure that the staffing models that are funded by that, those dollars are comprehensive and inclusive. The initial language said behavioral health professionals, and the majority of the Cahoots response team on the mental health side are not qualified mental health professionals. We're more of that kind of undergraduate level. And so we wouldn't even have qualified for that funding. What we're really advocating for is community involvement, separation from law enforcement, a broad range of credentials that can work on these responses, an opportunity to get to the place of 24/7 service rather than mandating that be, what you do right out of the gate. It took us 25 years to get to the point where we could effectively deploy teams 24/7. And I would hate to see, a community that's really working on this as an emerging model be hampered by the need to really try and focus on providing coverage at hours of the night where there just might not be the demand there yet.
Okay, thank you, Heather. So next up is Kathy Pemberton. Kathy, would you like to ask your question? And so maybe Kathy doesn't want to ask her question. Claire Barker might want to.
Hello, I'm sorry, I just unmuted.
Okay, there you go.
I just have one question. I raised my hand and then I'll get to my other question. But Tim, I've done a lot of emergency service work here in Boston and Cambridge in a number of different ways on outreach teams. And so it's one question that I think comes up here, and we've worked in Cambridge Police over the last 10 years, training in CIT, trauma-informed training, developing partnerships, doing multidisciplinary outreach teams. We've really tried to go down and start to develop relationships. And I think that there's been a lot of progress that can help inform and just keep us going to include a substantial alternative response, because that's what the police want, that's what the courts want, that's what the community wants. What happened when we would try to say, not cahoots or cuffs, but listen, let's get you to the emergency room, go voluntarily, and we'll get you what we can. Then they go there and there's an enormous backup because they closed our psych emergency service. So then they're in the waiting room and on a stretcher, and we have someone who has like an Adderall-induced psychosis or an agitated person that says, I'm not going to wait here, so I got to go. And then they go out and they were really close to Section 12. They're pretty dangerous, agitated, uncomfortable. And then it happened a lot where we would have to go back out and it got more complicated. And then we have had a number of injuries inside the Cambridge Hospital in the emergency room and on the units more recently, because we have a huge crisis and an overwhelmed system. So we have actually in this city a lot of events of victims of violence inside the hospital, and then across the community, there's just a lot of, risk and safety. I think an alternative response would reduce all of that. I'm 100%. I think anyone on the ground without my credentials can do tremendous job. But we also do have all of this untreated mental illness because nobody's getting the adequate treatment. So that's one comment. The other thing is, inside the police department, when I was in there in the family justice unit, we were doing, a ton of work. Like a lot of people would have quarries. So get them off their, these guys unhoused or women, they needed help getting their quarry cleared to get them housed. So we did a ton of work that wasn't getting done in the hospital, in public health, and, stuff around Section 12, stuff around Section 35, and so there was a bunch of work that belonged in the police department because of the court and the relationships. So I think one of my question is there both and? Is there something inside Eugene where you have those people doing that work and you have your whole program?
Yeah. The simple answer is yes. That's we don't have an obligation to be a part of that component of the process. We are involved, in civil commitment hearings or, advocating for needed services, really advocating for the folks that we see really, just being missed by the providers that claim to be caring for them. And so, our role really ultimately ends up being as advocates and leveraging our relationships to really call for the things that our community needs. In the absence of, adherence to the CDC guidelines around shelter-in-place orders for homeless encampments, when we saw the Eugene Police continuing to sweep encampments rather than provide them with the support they needed to maintain good hygiene and safe social distancing, we went to the paper, we went to the, public radio, we got on the news and started talking about what we were seeing. And so that's where we really see our role is when, you get those folks lined up in the hallways of the emergency room. We have an obligation to really speak up and say, hey, this is getting bad. What can we do, in prevention? What are the other lower level services we could bring in to really mitigate this and prevent it from happening in the first place?
Thank you.
Thank you, Kathy. So next up is Claire Barker. Claire, would you like to ask your question?
Sure. And my chat is really just a comment that a cost benefit analysis should include the benefit of not losing wages and not losing children to foster care if parents go into, if they're forced into the criminal legal system. And I just also want to appreciate everything you're doing, Tim, and also your language around the criminal legal system. I don't think it's appropriate anymore to call it the criminal justice system. So, and I think language matters in how we talk about these issues. So thank you.
Yeah, very good points, Claire. You're absolutely right. And for those of you out there, I'd encourage you to read Zach Norris's book, We Keep Us Safe, to further explore that point that Claire just raised.
Thank you so much, Claire. So Ted Hunt has a question about liability payouts as a result of Cahoots engagement. We touched on it, the topic a little bit earlier. Would you like to add anything to what you said earlier?
I think I would just really mention the remarkable safety record that we have here. In the 32 years we've been doing this, we've never had a serious, staff injury as a result of patient contact. The worst injury that I've seen on a responder in the 10 plus years that I've been with the program was when somebody slipped on the ice getting out of the van. It wasn't anything that had to do with a patient. And similarly, generally our patients, are experiencing a high level of care. And so we're not, making, payouts or settling things on a regular basis because we're just not harming, the folks that we serve.
So the next question is from Jessica Gillily. Jessica, would you like to ask your question? And apologies if I've just butchered your last name.
Sure, you were very close. It's Galuli. I was wondering from the call taker side, if call takers have specific criteria about when to dispatch Cahoots. Is it based on formal rules and protocols, or are the call takers exercising some level of discretion when deciding to send police versus Cahoots out?
definitely. There is a certain level of discretion, that the call takers have, but I would argue that's probably universal, regardless of what, public safety department you're working in. The general process, though, is that within the service agreement that we have in the cities we work in, there's a scope of work that uses language that mirrors what you'll see for different dispatch codes in the CAD system. And so then what that means is then our call takers are trained, and there's an entire section on Cahoots in the call taker manual that's really looking at the CAD codes, the call types that Cahoots is going to generally respond to. Most common are going to be check welfare, public assists, because those two really capture, folks in any manner of crisis. We respond for intoxicated subject calls, disoriented subject calls will go to Cahoots, generally speaking. But then there's one other one that really folks don't really kind of recognize at first glance as being something that police shouldn't be involved in, and that's death notifications and emergency messages. And so here in Eugene and Springfield, when we have somebody who has a loved one who has died in another state, medical examiners trying to just notify next of kin, that message is being delivered by Cahoots staff who have training in grief and loss and the ability to sit with you for the next hour, order you a pizza and make sure that you got a glass of water before they head out.
Thank you, Jessica. So Kathy's up and she has questions about how you work with youth. Kathy.
Thank you. I'm interested in how you work with, you do work or you collaborate with agencies that work with youth who are involved in violence or at high risk of getting into violence. How do you work with them?
Mm-hmm. Regardless of what the kind of more specific issue or point of intersection that a partner agency is working with or is trying to address, we really kind of have the same approach, is that there's an obligation for us to be educated by the subject matter experts locally. If we're going to be able to serve our community, we need to be hearing from the people who are, directly involved in that work. That also means that we're sharing some of our training, and so what you might see is us providing de-escalation training to a group who then comes in and talks with us about, using your example here, Kathy, what they're doing around violence interruption. And specifically with our work with youth, we saw a lot of opportunity to engage with young people through the schools, because that was where there was that strong sense of community and connection. Maybe that was, the safe environment for somebody as opposed to what they might experience at home. And through some outreach in the schools, by initially providing just kind of tragedy response, kind of send in a couple of staff over there to be, a sympathetic ear if there was a death at the school or, some sort of other traumatic incident. We eventually started to embed crisis workers and EMTs in all of the high schools in our community for drop-in clinics on a regular basis. And that's become its own program now. It's called Hoots because it's kind of the subsidiary of Cahoots, and it's helping out our teens in schools. But that now offers, a text-based crisis line in addition to voice and video chat. When there is traditional school happening in person, we'll have folks embedded in there too. Our school districts are even looking at what would it take to have kind of a dispatched Cahoots van that just focuses on the school system. So, violence interruption is an area where we have more of a role in really supporting and uplifting our partners in the community. And so sometimes that's doing joint fundraisers or, leveraging our resources to support them ourselves directly.
Can you also do things like help with jobs or anything like that, or do you not deal with that because that's not quite an emergency?
Yeah, that's not our wheelhouse. And we already, we have a bit of a challenge when it comes to mission creep already. It's hard to see a need, out there and not try to do something about it ourselves. But again, folks want to hear our voice, and so we find ourselves obligated to be advocates for, better, reentry programs, more opportunities for folks to, get a leg up and, get that experience. And so, one of the areas where we're doing a lot of the advocacy right now is in the Bay Area. You've got San Quentin sitting right there. Folks who are locked up in San Quentin have access to some really incredibly powerful training, and opportunities to learn more about how to, work in the mental health system. And how great would it be if you could get out of San Quentin and go and serve your community, right? And so that's where we see a lot of opportunity, is just leveraging our voice and the privilege that comes with it to really, advocate for these other groups.
Thank you so much.
Thank you, Kathy. So next question is from Ken. Ken Kavanaugh, would you like to answer your question?
Sure.
Question. Answer it too if you want.
Tim, I'll let you answer the question. So I find this fascinating. I love the idea, and definitely the cost savings is going to be, the driving decision maker with these other cities when we take it into other cities. But just planning ahead, thinking about not just the benefits, but also the pushback and the cost that they're assuming. Yes, we're taking away the risk of at times ill-equipped police to address these mental these mental illness derived problems. But what about the timing? If there's a risk, and if you, because being like fully of taking a full view of this and looking at the potential risk too, what's the risk of sending out the first response and then having an altercation that does warrant the police cover? And if something drastic happens in that time frame, and it could be literally 30 seconds to like 2 minutes, but do you see that's probably the biggest risk or the pushback on the police, or rather the city and the county?
I could see, some potential for that to be a point of pushback, but I had the opportunity to panel with Joe Maru from San Antonio, who's featured in that HBO documentary, Ernie and Joe Crisis Cops. And he brought up a really good point, which is, how often do patrol officers get shot and stabbed by somebody as soon as they walk out of their patrol car? We are assuming that this work is going to be dangerous because the folks who are responding to these situations aren't carrying a gun or pepper spray with them. When we focus on that, we really miss the fact that that there are a lot of people who feel powerless, and who are being oppressed, who are experiencing violence on a daily basis, and rather than focus on their potential to be dangerous, we really need to look at what it is that they're experiencing and how we can offer something different in our society.
No, that's a good point. Thank you.
Thank you, Ken. Brian Core. Brian, would you like to ask a question?
All right. Thank you, Sandra. Well, again, like everyone else has said, thank you, Tim, for this presentation. This has been great. And as you know better than I do, Cahoots has been seen as the replacement for police in the media, in many activist conversations. And so it's been great to really hear from you personally about how it works and what you do and don't do. And I really appreciate all the descriptions of how it's really come to be in the specific environment. But knowing that we can't just import it to Cambridge or any place else, I guess my question is really, are there 2 or 3 cities that you've been working with that you think have done a good job building a Cahoots-like program, wherever they are in the process? And especially, how are they approaching this sort of continuum between the 24/7 first responder, the law enforcement, mental health facilities? How are they managing that piece?
Yeah, the program in Olympia, Washington really comes to mind first and foremost, and this is the Crisis Response Unit. There are a few differences that are really key to distinguish the crew teams from Cahoots, specifically that they don't have an EMT as part of their response. But the reason that I bring them up as such a successful model is because they recognized that there was this hurdle that they weren't going to be able to get past with the fire department and who was going to be, staffing EMTs. And so then they shifted and said, well, then what does our community need for the second person on this response? What is it that we can do instead to really respond to, the folks who are being impacted by the lack of the service, the folks who are going to be accessing this when it's available? And that led to the development of initially peer support workers as part of their response, but then eventually a program called Familiar Faces, which is all peer led and serves as a point of connection from the mobile crisis teams, for folks that are, kind of in those rough spots. And so, Olympia has done a fantastic job of really just taking the time to listen to community members, to really consider alternatives and really get creative, rather than saying, okay, we're just going to embed this in the fire department. Additionally, we saw a lot of real, just powerful work being done in the city of Denver with the various stakeholders that they brought out to Eugene for a site visit in 2019. It wasn't just public safety, but it was reentry groups, folks who were doing homeless outreach, street medics. There was this whole continuum that was really represented there. And that really gave us an opportunity not just to present on what we do, but also facilitate conversations around how is this going to work? You know, how is it that folks are going to be impacted if this is our method, you know, versus this approach? And, you know, I think finally, I would also really reference what's going on in New York City right now, and as an example of where there could be some needed improvements. A lot of the feedback that we're hearing, you know, from stakeholder groups that are in contact with us is that there isn't enough room for them at the table, that there is a lack of you know, voices of lived experience. There's a lack of peers, you know, at these decision-making bodies, and you know, that's a problem. You know, this service is never going to be realized in any sort of meaningful way if you're not listening to the folks you're going to serve from day one.
Well, thank you so much. That's great. We appreciate it.
Thank you, Brian. So Sharon DeVos, you are up. Would you like to ask your question now?
Sorry, I had to. Yes, I am wondering if there is a recognition in the city of Eugene that so much money is being saved, and therefore they actually are providing alternative services like housing, drop-in centers, food. I have a family member who works as a doctor in a local Boston hospital. And so many of her patients are people who honestly just want something to eat and to get out of the cold or the rain. And it causes a significant problem for patients who really need to be in the hospital, particularly in the emergency room. And instead, the bays are all, you know, holding people who really don't need to be there, but do need services.
Yeah, you know, there hasn't been that direct, you know, we're saving $1 here, so we're going to shift it over here, at least not in public, you know, that we're aware of. The Eugene Police Department budget is being cut by $1.5 million, you know, this next fiscal year. And despite that, they've committed to helping us increase our wages for our first responders so that this can become more of a career oriented field rather than something that you do, you know, before you move on to the next thing. We have seen the city of Eugene invest more in housing, recognizing housing first as a, you know, a viable means to really meet the needs of our community. You know, again, you know, I can't say whether or not the motivations are because Cahoots is saving this money or just because our community is asking for these things in a very big way. You know, there was a petition last summer on change.org that advocated for reallocating $20 million from the Eugene Police Department budget to Cahoots. And that was flattering. You know, that felt good to see that we were appreciated on that level. But man, $20 million could house a lot of people, could feed a lot of folks, right? It could do so much more that would make it easier for Cahoots, you know, to work. That would make us less necessary, you know, in our own community.
Thank you.
I'm just so moved by all of your answers, Tim. So the next question is from Ted Hunt. He wants to know, does Cahoots have a walk-up center similar to the Winegate Center in Los Angeles?
Yeah, so Whitebird Clinic, which is our parent organization, is a federally qualified health center. We have a medical program, dental program. We have all sorts of outpatient behavioral health stuff. We have addiction treatment services, and then we have a host of crisis services. There's Cahoots. There's a phone line that you can call 24 hours a day, and that's the same phone number that you call today that you called in 1970 to talk to Whitebird crisis staff. And that crisis line is housed within a walk-in center. COVID has really impacted our ability to provide that walk-in service, but that is something that, you know, we're able to provide as needed. Most commonly, though, we see a lot of folks utilizing our day access services, and so that's going to be a place to just go get out of the weather for a couple of hours, you know, use a phone, access to a bathroom, a mailing address, you know, really kind of that home base.
Okay, and perhaps the final question for the afternoon is from Queen Cheyenne, who has at least one other question she would like to ask you.
Sure.
Oh, okay, thank you so much. I wanted to just follow up and ask you to just talk a little bit more about the importance of kind of community-based engagement and thinking about the first responder or the non-clinician first responder model. I know I keep coming back to this, but this is something that I know when we talked about, I was just really interested in hearing more about from your perspective in the work that Cahoots does, and really understanding how that can actually be an impactful way to create kind of the change that a lot of these different cities, and including Cambridge, as we're doing that here, can use to implement to really create sustainable change in our city.
Yeah, it becomes really easy to assume that, you know, a public institution is the authority to make all of these decisions. It's a very natural and, you know, comfortable place for folks in positions of power to be. What we generally see is a lack of recognition around who it is out in the community who might be doing this work already, and a lack of the voices, you know, of those who are being impacted by over-policing, you know, or a lack of an adequate mobile crisis response system. I think, for example, a good example is the Anti-Police Terrorism Project, which has MH First, which is a mobile crisis completely divorced from any sort of public safety system in Sacramento, is also working on some really incredible things in Oakland, but they haven't really had a seat at the table with, you know, macro and, you know, other initiatives around mobile crisis. And that's led to conflicts. When I was down in Oakland in 2019 to, you know, do some presentations and meet with some public safety folks, I got a lot of feedback and pushback from the APTP that that I was, you know, kind of walking all over stuff that they've been working on for years. And they were right. You know, they hadn't been at the table, and instead me, a white man, was coming in to talk about how their public safety system needed to be reshaped. That's an issue. You know, our general best practices that we would recommend is 51% lived experience at any sort of task force or coalition, any sort of planning group, that there be an emphasis on, you know, peer-led services and as much distance as possible from traditional public safety, you know, in the system design. We advocate for starting, you know, with a separate phone number from the rest of law enforcement. And ultimately, when we're engaging with a community, if they want to do some consultation with White Bird Clinic and talk to me about how we're doing things here, one of my first questions is going to be, who is it that you know in your community that's already doing this work? What are the street outreach teams? You know, who's out there feeding folks under the bridge? You know, who's there when camps are getting swept, helping folks relocate? You know, who is it that really knows what's going on? Have you talked with your local NAMI chapter? You know, who are you talking with your neighborhood associations, mutual aid networks? You know, we talk to each other. You know, we're in communities, right? And that voice, that perspective is vital to any sort of rollout of a program. If you don't include those voices, if you kind of just march forward, build something, put it out there, chances are it's going to fail, right? And then that's going to reinforce that municipality saying, this didn't work the last time we did it, so we're not going to invest in those resources again. You know, and we don't want to see that happen. And the best way to really do that is to build a table big enough for everybody to have a seat at it. You know, the Vinny Cervantes with Dasher in Denver puts it really well. So often it's, you know, we see our language, but we don't hear our voices. And we got to shift that. You know, there's an obligation. Every city, every county has an obligation to really take the time to listen. And I hope that they do. That's what we're encouraging them to do.
I feel like I should just let it end at that point, because that was just a really kind of powerful statement to make. But I do have one last question, since I have you for 2 more minutes. And that is, how do you not become a victim of your own success? White Bird Clinic is a relatively small outfit, and you're doing so much, not just in your communities, but also providing so much support and information to others so that they can build up. And of course, we want that, but then what impact does that have on your own, the functioning of your own organization?
You know, education is a component of our mission statement. And really, we're looking at this as a crisis. You know, that's what it is. It's a public health crisis. And just like we would respond to a crisis in our own community, we have an obligation, you know, to really kind of speak up about this. I feel very fortunate that our organization has supported me and my colleagues in having the time and the opportunity to really get out there, you know, spread this message. But at the end of the day, we're doing it because we're called to it, you know, and in order to kind of keep it sustainable, it takes a lot of humility, takes a lot of dedication, and it takes a lot of time to really listen. You know, just like we encourage all those other municipalities to engage with the communities that are being impacted by the lack of resources, we're doing the same thing ourselves. You know, I spend time listening to peer support in New York City. You know, I'm very excited to spend some time with the Anti-Police Terrorism Project. You know, various grassroots organizations and community groups are where the experience is. And just like I said before, you know, we need to listen, you know, and help lift up those voices.
Well, Tim Black, thank you for all that you do, all that you have done for your community, for the inspiration that you've been to so many of us across the country, for providing a vision for how to move forward without the presence of police and some of the harm that they bring to so many of our communities. I really appreciate it. I've learned so much by talking to you. Thank you. And I'm sure our community would like to thank you as well. So we give a
thank you. And Sandra, this has been a fantastic conversation. Just a pleasure. Yeah.
Well, let's stay in touch. Okay.
Absolutely. Yeah. Thank you.